Hi everyone, this is Neel Raithatha, consultant audiologist and director of earwax. Thank you for joining me in my latest video using the WAXscope. And here we have a patient who attended with bilateral fully occluding earwax, and I'm just commencing with this there right ear first. I immediately instilled some medical grade olive oil spray to help coagulate and bind this wax together. It appeared quite soft and mushy, and what I'm attempting to do now is just lift it off the canal walls. Because it's so impacted, it's up against the canal walls of the ear canal, and therefore to mobilize it I'm just having to separate it. And I'm currently working on the, well, I was on the back part of the ear canal. I've now just moved to the front section of the ear canal, so the anterior canal wall, and there's a thick blanket of skin here. So that glossy appearance just below the suction tip is actually some dead skin that's enveloped itself around the wax plug, but it's still semi-attached to the ear canal. So we're going to come back to that in a moment. I'm now just going to the midsection of the canal wall, but because it is quite a mushy, sticky, soft consistency, it is partially blocking up the suction probe as I'm removing it. So I think in a moment I will apply some more oil. Sometimes with a wax plug like this, you're having to do it in layers. You put some olive oil spray in there and you bind the surface of the wax together. You remove that part and then you move on to the next section of the wax. So removing earwax does actually require a lot of patience, and it's probably one of the things I've kind of developed. Not that I was impatient before, but I would say I've become even more patient upon removing earwax, because truth be told, when I first decided to get trained in earwax removal, I thought it would be pretty straightforward, because I thought, well, there's a bit of wax in there and you put the suction tip and you just vacuum it. And partly it's because I used to observe a lot of ENT doctors. I got a couple of good friends who are ENT surgeons, and when I used to watch them, they were so good and efficient. It gave me a false sense of what the procedure actually entails and how difficult it can be to remove earwax, because it's not straightforward, and sometimes you think the wax should just come out immediately when you're suctioning. And I know a lot of viewers think that based on some of the comments, but have it from me, it's a lot more difficult and complex than it appears to the eye, especially when you're watching videos like this. In fact, an audiology colleague, well, I would say more of an acquaintance, actually said to me that I'm part of the reason why, and I see why they say it. I don't take it in a bad way, but myself and a few others who upload videos on social media are part of the current problem, in the sense that we make it appear so easy. Now, it's not easy, and I don't think I make it look easy, but well, I certainly don't feel like it's easy, and I do mention that a lot in my videos, but I understand where they're coming from. If I was watching someone else's video and I had no idea and I've never performed the procedure again, I would think it's pretty straightforward. I actually had a nephew of mine attend about a year ago for work experience, and he was observing, and I had a really busy clinic that day, and I could sense that he wasn't overly impressed, because he was like, well, I could just tell by his body posture and his facial expressions that, why is Neil making this look more difficult than it is? And then I got my nephew to simulate and role play the procedure in a mannequin head, and I think that's when he realised actually it's a lot more difficult. He really struggled to even get the instruments into the ear, and I think he was I managed to obtain his respect. Not that he didn't respect me before, but I think he understood that his first impressions were incorrect, and it's not an easy thing to do. So I'm slowly bringing this away. I need to be careful that I don't embed the suction tip too much into the wax, because if I do, it will just block the tip of the suction probe. So I'm almost just hovering over, kissing the surface, and as you can see, this is slowly coming away. Now, I could have potentially used the correct in this ear as well, but by this stage I could feel the wax was coming out with the suction probe, so I just continued, and that's the more lateral aspect. So this wax is still stuck to the posterior canal wall. So again, and this is why suction is quite good in these cases, because you can use the suction power to elevate and separate the wax from the canal wall far better than I would say correct. Sometimes, obviously it has its uses, I use it a lot, but you can sometimes smear the wax. Now this is probably a bit too firm to smear, so it probably would have been okay, but you may not get a clean separation from the canal wall, so there may be some residual wax there, which you may then have to go back in with the suction to remove in any case. When you watch their left ear, the wax is a lot softer in that ear, so that definitely wasn't suitable for using a correct, because that will just smear the wax. Now this last bit of wax is quite deep in the inner third. You can see the isthmus there, so the narrowing of the ear canal, and actually some of this wax was beyond the isthmus. As I was bringing it out, you may have seen the wax come past that narrowing, and I think this final plug is the last plug in this ear, so I'm just going to dilate open the ear. They have got an attic retraction of the eardrum, you can see that there. That's been a long-standing problem for the patient. They do suffer from negative middle ear pressure due to chronically blocked eustachian tube. So the eustachian tube is the pressure equalizing tube that connects to the back of the nose, the nasopharynx, and to the middle ear cavity. And we want the air pressure in the middle ear to be more or less equivalent to the air pressure in the ear canal. And when the air pressure is at an equilibrium either side of the eardrum, or not too dissimilar, that's when the eardrum is at its most mobile. And air travels up the middle ear via your nose and then up a tube, as I made reference to the eustachian tube. Now the eustachian tube, under normal resting state, as it is right now, my eustachian tube is shut, and it's shut to prevent upper respiratory tract infections travelling into the middle ear and causing an infection, but it's also shut to prevent you from hearing yourself breathe. If your eustachian tube was permanently open, every time you inhale and exhale, that air will enter and exit your middle ear, and quite often you can see the patient's eardrum pulsating in line with their breathing. We call that patulous eustachian tube. And also some patients who have permanently open eustachian tubes, they hear themselves twice, so it's a mismatch. They get a muffled sound of their own voice, and that's because they're hearing themselves in three ways. Now, we all hear ourselves in two ways. The first way is bone conduction. So when we talk, the sound vibrations cause the bone around our ear, the temporal bone, to vibrate, and these vibrations are then transmitted directly to the organ of hearing. So we call that bone conduction. We also hear through air conduction. So when I'm speaking right now, my voice is being projected out of my mouth, and it's traveling into my ear by the ear canal, and it's vibrating against the eardrum. But with patients who suffer from patulous eustachian tube, their voice also travels up their nose, up the eustachian tube, and it vibrates the inside of the eardrum. And because sound has to travel different distances between entering your ear and up your nose to reach your eardrum, you can hear yourself twice. We're talking a fraction of a millisecond, but that's enough for you to perceive your voice as being very muffled. So yeah, the eustachian tube under normal resting state should be shut for those reasons. And I think on average it's about 4 times a minute. So when you swallow, yawn or chew, the muscles at the base of the eustachian tube, where it connects to the back of the nose, the nasopharynx, they contract, and it causes the eustachian tube to momentarily open. And during these brief moments, air can either travel into the middle ear if there's negative middle ear pressure to equalize it, or if there's already excessive air in the middle ear, it allows air to escape to again equalize it with the atmospheric air pressure. Also, sometimes we could have some middle ear fluid collecting in the middle ear. When the eustachian tube opens, it allows some of this fluid to drain out of the middle ear into the back of your nose. Now, in some people, the eustachian tube fails to open when it should. So it could be that they've got inflammation at the back of the nose, obstructing the eustachian tube, or some mucus there. It could be that the muscles that contract and cause the eustachian tube to open have weakened or paralyzed. Some patients may have a physical obstruction, so they may have a nasopharyngeal mass, for example, which needs investigating because that's by ENT, because that's cancerous. They may have a large nasal polyp, a deviated septum, enlarged turbinates, adenoids. So you can have a physical obstruction there, or a deviated septum even. Some patients may suffer from rhinitis or sinusitis, and this inflammation again can cause blockages at the back of the nose. And if your eustachian tube fails to open, all the remaining air that was present in the middle ear gets absorbed by the mucosal cells that line the middle ear. And when this air is absorbed by the mucosal cells, it pushes out fluid from the cells into the middle ear. But it also creates a vacuum. It's like a cupping effect, so your eardrum gets sucked in. Exactly the same as when you're flying and you're descending on an aircraft, particularly if it's a sudden descent. If it's a slower, gradual descent, your eustachian tube may be able to equalize it. But if you have a sudden descent, your eustachian tube just isn't able to cope with it, and the cabin air pressure as you descend goes into your ear canal and it pushes the eardrum in. And one of the things that you can do to rectify that is either perform the Valsalva maneuver or the Toynbee. So the Valsalva maneuver is when you close your mouth, pinch your nose, and you gently blow, don't you over-exhaust yourself, into your nose. But because your nose is pinched and your mouth is closed, you're trapping that air inside your nasal passages, and that air then causes the muscles to contract at the back of the nose where the eustachian tube is connected to, and it opens the eustachian tube, and that air then travels up your nose, up the eustachian tube, and it ventilates the middle ear, equalizes it, and it causes the eardrum to pop out. Sometimes people perform the Toynbee maneuver. That's when you pinch your nose, close your mouth and swallow, and it has a similar effect. So you can see they've also got an attic retraction there. It is clean, there's no dead skin, debris collecting, so there's no cause for concern of a cholesteatoma forming. Well, I hope you enjoyed that video, guys. Take care, keep well, and speak soon. Bye.